Right, a very good afternoon, senior colleagues and colleagues on the call. It's 1 o'clock and we're about to recommence the webinar. We must also apologize for the initial hiccup we got. And we believe that hopefully that is resolved for now. I wouldn't know, maybe I need to crave the indulgence of the DG to help us to restart everything all over so that we don't carry over the initial remarks. And most likely we may also be having new colleagues joining the call now. Since the DG is on the call, it will be helpful, sir, if you don't mind, so that we have a fresh start to everything. So we're starting, and I think we have more than 100 participants on the call already, which is good to kickstart the processes. The Director General, Nigeria Center for Disease Control, Dr. Ifedayo Adetifa. It's nice to have you back, sir, and the team is ready, and we'll be glad to have your formal welcome and opening remarks. The DG, sir, over.
All right, thank you very much, Beardo, and again, warm welcome to everybody who's made the time to be at this webinar. We're very sorry for the hiccup with the first attempt. This was due to circumstances beyond our control, but we have learned a lesson from that. And as we expect that there will be perhaps several in the series of this webinar, we certainly will make sure or do our best to make sure that there is no repeat of the previous incident. We are having a webinar to discuss this diphtheria today because we have an ongoing diphtheria outbreak in the country. And as I'm speaking, I am in Kano, which is the epicenter of the outbreak at the moment. To where I've gone to express support and to have high-level advocacy to state authorities and partners, and to make sure that we have the best response that is possible. So what we have planned today is to speak about diphtheria, because this is not a well-known condition anymore, given what it's a vaccine-preventable disease that has not been seen for a while, given the high levels of vaccine coverage that historically existed. But now it is here, and we all need to understand fully what this condition is, how it is diagnosed, who it affects, and what we all need to do about it. And we have a set of excellent faculty who will take us through that, through their individual presentations. But we also have the larger group of panelists who will take on the questions and perhaps add on additional information or answer questions as the case may be. So welcome. I can see we now have 138 participants. I hope we return to the numbers that we previously had during the first attempt, but it's a pleasure to have you all here, and I promise this will be a very interesting webinar. So over to you, Beardo. Thank you very much.
Thank you very much, Director General. Thank you for those warm welcome remarks. All right, so like the DG rightly mentioned, we are responding to the current outbreak of diphtheria in the country, and it's gladdening to see the cross-section of participants on the call across different parts of the country and even outside, emphasizing the interest in this conversation. So as we move on in this meeting, presentations are going to commence now with Dr. Bola Lawal. But may I kindly request that we make use of the Q&A box for anyone who's got any question, so that it's easier to collate, track, and be able to address them appropriately. So again, please let's make use of the Q&A box to put in the questions we may have in this regard. So the floor is open. So Dr. Bola Lawal, the lead Diphtheria Pertussis Technical Working Group at the Nigeria Center for Disease Control, will be taking us through the epidemiology of diphtheria, current situation in the country. Dr. Lawal, you have the floor, please. Over.
Okay, thank you very much, Mr. Biadu. Good afternoon, DG. Good afternoon, everyone on the call. My name is Bola Lawal from the Nigeria Center for Disease Control and Prevention. I lead the National Technical Working Group for Diphtheria at NCDC. And over the next few minutes, I'll be taking us through the first presentation of this webinar series titled Epidemiology of Diphtheria, Current Situation in Nigeria. Due to the availability of safe and effective vaccines, the global burden of diphtheria has significantly reduced over the past 5 decades. So much so that clinicians and surveillance officers have, in quote, forgotten about diphtheria. So what is diphtheria? Diphtheria is a serious infection caused by Corynebacterium species. It's primarily a respiratory tract infection, but may occasionally be cutaneous. Most diphtheria infections are by toxin-producing Corynebacterium diphtheriae. Humans are the only natural host for Corynebacterium diphtheriae, with carriers of the bacteria serving as reservoir. It can be transmitted directly from a susceptible individual to another, directly through respiratory droplets by coughing or sneezing, or indirectly through contact with skin lesions or contaminated proteins or objects. Transmission can occur as long as the bacteria are present in discharge and lesions, which is needed 2 weeks or less, and really longer than 4 weeks. Treatment with cheap and readily available antibiotics promptly terminates shedding of the bacteria. Symptoms begin to appear 2 to 5 days after being infected. The infected individual may present with fever, sore throat, and cough, as well as neck swelling. In severe cases, patient can present with the classic whitish membrane, a pseudomembrane, which can obstruct the throat and airway, leading to difficulty in swallowing or breathing. Complications arise when toxin binds to body tissues, leading to inflammation and damage to heart muscles, nerves, or kidneys. Deaths of up to 10% have been reported in diphtheria outbreaks, and are higher in settings where diphtheria antitoxin is unavailable, like we experienced in the earlier phase of the ongoing outbreak in the country. For diagnosis, 2 samples should be collected from every suspected case as first contact. That will be the pharyngeal as well as the nasal swab. Specimens should ideally be taken prior to commencement of antibiotics, but that should not in any way delay commencement of treatment. The gold standard for confirming diphtheria is by culturing the organism and demonstrating toxin production using the modified LF test. PCR done to detect the presence of the A and B subunit of the diphtheria toxin gene is also helpful in nailing down the diagnosis. The mainstay of treatment is the administration of diphtheria antitoxin via the intravenous or intramuscular route. The earlier diphtheria antitoxin is administered, the better the outcome, as it's been documented that the time interval from onset of symptom to administration of that is inversely proportional to the outcome. Antibiotics therapy with penicillin or erythromycin is also required to clear the bacteria from the infected person, thus halting the production of toxins as well as the transmissibility to another susceptible host. Being an infectious agent which is easily transmitted to others, cases are to be isolated. For contacts, vaccination is to be completed. Vaccination to complete the primary series or use of age-appropriate booster is needed, as well as prophylactic antibiotics treatment with penicillin or erythromycin. Contacts should also be monitored and followed up for at least 7 days to observe if they develop signs and symptoms suggestive of diphtheria. Diphtheria occurs worldwide, talking about the distribution, particularly in countries with suboptimal vaccination coverage. Nigeria, of course, is inclusive with a third dose of pentavalent vaccine coverage of about 53%. Before the EPI, that's the Extended Program on Immunization, began in 1977, about 1 million cases of diphtheria and 50 to 60,000 deaths occur globally each year. The burden of diphtheria has decreased over time with the introduction of diphtheria-containing vaccine. The chart on the right with red bars shows the decline in the global burden of diphtheria following the introduction of diphtheria chocolate-containing vaccine. While the chart with the blue bars below shows the declining burden of diphtheria in the Pan-African Health Organization region with rise in vaccination coverage, illustrating the impact of vaccination on the burden of diphtheria. This chart shows the global distribution of diphtheria cases by WHO regions from 1980 to 2020. The Southeast Asia has consistently accounted for the highest burden globally, except in the 90s when the Soviet Union, particularly speaking, Russia and Ukraine, had a large outbreak of diphtheria. Africa until recently has continued to report low cases of diphtheria. However, this can be attributed to the poor reporting from the region, given that Africa has the poorest reporting rate for diphtheria globally. There is no particular trend in the burden okay, the chart actually depicts the distribution of diphtheria cases in Africa, and as you can see, there are white countries shaded white, depicting that no report was actually generated. From this region. As you can see here, if you can closely, in 1980, Nigeria is said to have reported some cases. However, in 1995 as 2019, no cases were actually reported. There is no from the chart there's no particular involved of diphtheria cases in Nigeria are shown in the chart of the screen, and this is largely due to the poor reporting that has been reported. A number of studies in Nigeria, as illustrated here, have shown that diphtheria might be more common in our environment than data is. Some of these studies actually revealed the following. One, diphtheria is still a country, and there's the poor vaccination against diphtheria being the major vaccination against diphtheria being the major for outbreaks, and suboptimal capacity for laboratory confirmation also exists, as well as no access to that in country. We also actually saw the non-availability of standardized surveillance and response guidelines to actually guide response activities across the country. And last but not the least is that there's obviously a gap in vaccination policy as well as guidelines. Just to remind us quickly of what public health surveillance is all about. We have on surveillance is ongoing systematic identification, collection, collation, analysis, and of disease occurrence, health events, take timely and robust public health action. As you can see highlighted in this definition, ongoing systematic, meaning that it is not a one-off activity, that we keep going in circles as we get in the next slide. And the essence of surveillance is not just to generate data for academic purpose, but rather to inform appropriate public health action that will help reduce the morbidity and mortality of diseases in question. This chart actually shows the common functions of surveillance, and it starts with identification. Having identified cases, it is expected that these cases will be reported to the appropriate authority. From the data gathered, analysis will be done, and some of such analysis will be interpreted to actually make some sense out of it. Based on the findings from the analysis, we go ahead to prepare and respond and communicate findings, our response as well to the needed authority. But after all this, we also need to actually evaluate the entire surveillance system to actually ensure that it's actually the set objective. This chart was particularly depicted in a circular manner to re-emphasize the fact that surveillance is actually not a one-off event. Rather, it is an ongoing process that helps in controlling or reducing morbidity and mortality of diseases under surveillance. This chart actually shows the reporting for surveillance data. It's actually quite important for us to understand how surveillance data move from one point to the other. so that at each level we know where exactly to reach surveillance data to. The lowest level is actually at community level. This is from there to the health facility, and by this health facility we mean irrespective of whether it is public, private, irrespective of whether it is primary, secondary, or tertiary. All facilities are expected to receive information from the community, and from there it is being transmitted to the LGA, DSNO at the LGA. From the LGA, surveillance data move to the states. From state level, it moves to national. As we can see, to the right of this flow is actually the laboratory. Laboratory actually a key role as well as surveillance is concerned. Unlike other surveillance information moves from community to health facility, LG state, laboratory is such that it can actually interface with the various levels we have in this chart. From the health facility, you can to the lab, go straight to the lab, as well as from the LGA state, and even from the national level, we can all communicate with the lab. Based on surveillance response guideline, IDSL guideline, which was actually released last year, the latest edition, we have 45 prioritized diseases in the country, 24 of which are immediate case-based reporting, and this is exactly where diphtheria falls into. Others are either for week reporting or monthly reporting. As for diphtheria, as mentioned, is actually a case-based report, follows the case-based reporting system. By that, we mean that all suspected cases are to be reported and investigated. And by investigation, we actually means two main things. Firstly, filling the case investigation form to capture all epidemiological or relevant epidemiological investigation that relates to the case. And next is actually to collect appropriate samples for laboratory confirmation. By the time we did these two, the case is said to have been completely investigated. And also one mentioning that surveillance for diphtheria should actually be health facility based on reasons that will later expatiate on as we move on into. So what is the case definition for diphtheria? A specific case of diphtheria is actually defined as any person with illness of upper respiratory tract with the following: pharyngitis, nasopharyngitis, tonsillitis, or laryngitis, and the classical adherent pseudomembrane, which is actually a thick grayish whitish patch of the pharynx, tonsils, larynx, and or nose. And while a confirmed case is actually defined as a person with corynebacterium species isolated by culture and positive for toxin production, regardless of whether the person presented with symptoms or not. We also want to go briefly talk about the final classification, and broadly we have what we refer to as confirmed cases. This actually refers. Okay. So after we want to talk about final classification, broadly we'll talk about confirmed cases. Confirmed cases here refers to a combination of lab confirmed cases, epi-linked cases, as well as compatible cases. Lab cases are actually lab confirmed cases refers to a person isolated by culture and positive for toxin production, regardless of the symptoms. What epidemiologically linked cases refers to anybody that meets the definition of a suspected case and linked epidemiologically to a laboratory confirmed case. While clinical compatible case is a suspect case that acts both a confirmatory lab test result and epidemiologically to a lab confirmed cases. Once confirmed cases actually refers to the summation of these three groups or subgroups, which are the lab confirmed, linked, and clinical compatible cases. Discarded cases on the other hand refer to suspected cases that meet either of these criteria, having corynebacterium species but native tests that is not to zoonotic corynebacterium, or negative for PCR diphtheria toxin. So what is the current situation of the outbreak of diphtheria in Nigeria as we speak? On the 1st of December 2022, NCDC was notified of a suspected diphtheria case in two states, Kano and Lagos states. From Kano, cases were reported from Aminu Kano Teaching Hospital, as well as Murtala Mohammed Specialist Hospital, while in Lagos, cases were reported from University of Lagos Teaching Hospital. Upon receipt of this notification, rapid response teams were deployed to both states on the 12th of December 2022. And the main objective of actually deploying them were firstly to confirmed the existence of the outbreak and render support to the state in the area of responding to the outbreak. Eventually, diphtheria outbreak were confirmed in both states, and NCDC is currently still supporting response activity in multiple states across the country, namely Kano, Katsina, Lagos, Osun, as well as Yobe states. Cumulatively, as at Epi Week 5, 2023, a total of 522 suspected cases were reported from these 5 states: Kano, Yobe, Katsina, Lagos, and Osun. Of these 523 cases, 216, amounting to 41.3%, were confirmed cases. 80 were discarded cases. Those depending classification are 106, amounting to 20.3%, while we have 121 cases still unknown, based on the fact that detailed information was actually not captured for these cases. Now, breaking down the confirmed cases further, of the 212 confirmed cases reported, 14 were actually lab confirmed, while the remaining 202 were clinically compatible cases. Looking at the distribution of these cases across the 5 states that have actually reported these cases, like I mentioned earlier on, 523 cases were actually reported. Kano has the highest burden, and you recall the DG mentioning the fact that Kano is the epicenter. This is as a result of the high number of cases that currently being reported. So as at Epi Week 5, a total of 396 suspected cases were actually were reported from Kano, out of which 211 are confirmed cases, while 64 are discarded. Next on the list is Yobe with 78 suspected cases, out of which 2 were confirmed, while Katsina reported 34 cases, and none of the cases so far has been confirmed based on the laboratory investigation conducted so far. Lagos reported 14 cases, out of which 2 were confirmed, while Osun reported 1 case, and that one case turned out to be a lab confirmed case. This chart looks at the epi curve of cases right from Epi Week 9, when this outbreak, the first case was identified, up until Epi Week 5. As you can see, NCDC RRT rapid response team was actually deployed to the states in Epi Week 50, that is in the year 2022. After such deployment, as you can see from the chart, we've actually recorded an upsurge in the number of cases. This is likely to be attributed to the fact that while being deployed to the state, a lot of sensitization was actually being done among surveillance officers, and this actually increased or improved the index of suspicion amongst clinicians and surveillance officers, and such cases were readily more identified. Looking at the confirmed epi curve for the confirmed cases, similar to what we had for all cases, after the deployment of the national RRT, that's the rapid response team, to the affected state, and in Epi Week 50, the number of confirmed cases is said to have actually increased. Of the 216 cases reported, 40 deaths were actually recorded, giving a case fatality rate of 18.5%. Giving a case of 18.5%. However, that following the commission of cases tree, and knowing fully well what we presented earlier on, that is the mainstay of management of diphtheria in the country, NCDC in collaboration actually sourced that to be shipped to the country. Prior to now, like the DG rightly mentioned in his opening remarks, we had no positioned in the country. However, upon our notification of these cases from this state, particularly Kano and Lagos, that was actually being prepositioned in the country. And upon introduction of that, as we later see in the next slide, significant improvement has actually been recorded in the case fatality rate. So this chart actually showing the trend of weekly case fatality rates in the country. Upon the introduction of, prior to introduction of that, the case fatality rate was as high as 100% in some cases, and the lowest that was actually recorded was 33%. However, with the introduction of that, we've actually recorded a significant decline in the weekly case fatality rate, and it was as low as 6% in April 4. Looking at the agency distribution of the cases of the confirmed cases, 216 confirmed cases recorded, 184, that's 85.2%, we are aged between 2 to 14 years age, and this actually caught across both sexes. The age group 5 to 9 years actually accounted for the highest burden, amounting for 7% of all confirmed cases reported. There's a bit of male preponderance with 111 cases being recorded by the fields, that amounting to 51.4% of all confirmed cases. Cases are also being reported amongst adults, with 16 cases being aged 20 years and above, while in fact, 5 cases have actually been reported amongst infants. And looking at the vaccination status of the 216 confirmed cases, 27 amounting to 12.5% were fully vaccinated, while 84 are unvaccinated and 20 are partly vaccinated. Looking at the vaccination status by age group, the age group 5 to 9 years actually accounted for the those that are actually mostly vaccinated, which is 15%. And that takes us to the summary of the response.
Dr. Lawal, you have 2 minutes more. Dr. Lawal, you have 2 minutes more.
In the area of coordination, we had the establishment of the National Technical Working Group for Diphtheria, which is actually a multi-disciplinary and multi-sectoral working group bringing across, which actually brings together stakeholders across various sectors and disciplines. And essentially, the primary aim of this group is to constantly monitor the outbreak and coordinate response activities across the country. We've also supported with deployment of rapid response team to Kano, Katsina, Lagos, Osun, and Yobe. Currently, we are together with the DG in Kano State, trying to actually support the ongoing response. We also supported the establishment of the incident management system for diphtheria in affected states, notably in Kano as well as Lagos states. And then there's ongoing collaboration with the National Primary Healthcare Development Agency, given the fact that this is vaccine-preventable disease, and the agency responsible for vaccination have a key role to play in this response. We are equally collaborating with other partners, which include UKHSA, who have actually played a major role with regards to building laboratory capacity in preparation, building laboratory capacity for diphtheria. As well as MSF. MSF is actually present in Kano, where they are actively supporting case management. They supported the Ministry of Health in Kano State in setting up the treatment center that is currently being in use. Breakthrough Action Nigeria is actually supporting the area of RISCOM. Others that are actually supporting include WHO, UNICEF, and Resolve to Save Life. We are also, as a way of actually giving feedback to the larger community, weekly situation report is actually being developed and shared on NCDC website to regularly update the larger community as regards what the status of the outbreak and response activities being conducted so far. In the area of surveillance, prior to now, there was actually no surveillance tool in the country that will actually guide surveillance activities surveillance activity for diphtheria in the country. But upon a notification of this outbreak, NCDC together with partners actually went ahead to develop and disseminate surveillance tools across the country. And this includes case definitions, case investigation forms, line listing templates, advisories, amongst others. We also conducted some form of sensitization and training of clinicians as well as surveillance officers on the presentation, prevention, and surveillance for diphtheria. There's ongoing harmonization of surveillance and laboratory data from across all states and labs. In the area of laboratory, there's ongoing assessment of capacity of state lab to be able to capture diphtheria. As we all know, the lab is actually key to confirming diphtheria, and it is expected that at the state level, there should be capacity for such confirmation. We've assessed labs in Lagos, Kano, Osun, Yobe, Katsina, and plan is actually on board to assess labs across all the country and see where the gaps are and what needs to be done to close these gaps. Earlier this year, a training was actually conducted at NRL Gadwa to actually build the capacity of laboratory physicians and scientists from selected states across the country, so as to be able to confirm diphtheria in the laboratory in their respective states. There's also ongoing provision of sample collection materials to aid appropriate sample collection and transportation. And the National Reference Lab in Abuja is also conducting culture and toxin production tests using the ELEC as well as the PCR tests. There's ongoing drug sensitivity tests at the NRL so as to be able to identify the medication or the drugs that the antibiotics that the bacteria is actually sensitive to, in order to guide against judicious use of antibiotics in the country. In the area of case management, like I mentioned earlier on, efforts have actually been made to actually pre-position that diphtheria antitoxin in country, as well as distributing it to states in need. So far, we've actually distributed to high-burden states, particularly Kano, Lagos, and Yobe states. We've developed and disseminated standard operation practice for that use, knowing fully well that this is not a drug that is commonly available and in use in the country. We've gone ahead to actually develop SOPs that will actually guide clinicians on how to use the diphtheria antitoxins. With the support of MSF and the Kano State Ministry of Health, the diphtheria treatment units have actually been established in Kano and is currently being used in managing diphtheria cases in Kano. As we speak, about 76 cases are currently on admission in the isolation wards being created. There's also development of protocol for prioritization of diphtheria cases for that use. We don't intend to use this, but however, given the fact that diphtheria antitoxin is actually not we don't have much supply even globally, and in a situation whereby we find ourselves whereby we need to prioritize, we've gone ahead to actually develop the protocol that will help in actually guiding this in a scientific manner. In the area of risk communication, we've actually conducted media appearances and engagement of diphtheria with media stakeholders. We've published the diphtheria frequently asked questions on the NCDC website to actually provide more information to the public. We've pre-tested our IEC materials and we'll be disseminating any moment from now. We are currently, like we are doing now, we'll be hosting on a regular basis diphtheria webinar series to further enlighten the public on what diphtheria is. Of course, the response have not been without certain bottlenecks. We've identified bottlenecks in the area of weak laboratory capacity, particularly at the subnational level. And to this effect, we've engaged in training staff laboratory. We've also assessed some of the labs, and we'll be working closely with states to ensure that their labs have been optimized. We also observed that prior to now, there's no national guidance on diphtheria surveillance and outbreak in the country, particularly as it relates to vaccination and that use. Consequent upon that, we actually recommending, which has actually been implemented, the establishment of the diphtheria working group, technical working group at the national level, as well as the development of the diphtheria surveillance and outbreak guideline, which I will hope to round up on before the end of the first quarter. Given that there is a huge gap as regards vaccination, knowing fully well that what we currently have is just routine immunization within the under 2 age group, and the highest burden of the disease actually amongst children 2 to 14 years of age, of which there is currently no policy or guidance as regards vaccination in this age group. So having identified this limitation, there is need to actually gather evidence to support the introduction of such policies. And to do this, we are actually recommending leveraging on the existing data that was actually collected from the NICE survey conducted in 2018, as well as conducting several surveys in selected states. Other bottlenecks that have actually been identified is in the area of surveillance to lack of timely and availability of data at the national level, as well as need to increase awareness in the country. In conclusion, I want to actually make reference to the theme of this webinar, which is actually diphtheria outbreak in Nigeria, a case of re-emergence or improved surveillance. Having listened to this conversation, I would want to leave us to answer this question on our own based on what we've actually presented. But in conclusion, again, diphtheria is very much with us, given the suboptimal coverage of pentavalent vaccine in the country. The burden of diphtheria is underestimated, as shown earlier on, due to poor surveillance as well as limited capacity for laboratory confirmation. For effective control of diphtheria, there's need for high index of suspicion among health workers, which is partly why we're organizing this seminar, strong laboratory capacity, timely access to that, and most importantly, vaccination against diphtheria. On this note, I want to say thank you and over.
All right, thank you very much, Dr. Lawal. I struggled to see if you can reduce the time for the presentation, but it's obvious you have a lot and lots to really dish out. Thank you. Distinguished colleagues, I can see that the chat box has been crowded already with information, personal information. We've said earlier on that if you have registered through the link before joining, there is no need to repeat putting your details on the chat box to crowd it. However, for specific questions, please, again, let's make use of the Q&A box. Otherwise, we won't be able to track it if it's in the chat box because of the information we have there at the moment. Great presentation again, Dr. Lawal. A lot of issues raised, and I believe when we come to the panelist discussion, we'll be able to have time to dwell more on them. So in the interest of time, we just have to move on. So please, all questions, please let's keep them coming. We will come back when we have the section for that. All right, so the next presentation is going to be taken by Dr. Fatima Hassan Hanga from Aminu Kano Teaching Hospital in Kano State. And Dr. Fatima will be taking us through clinical presentation and management of diphtheria, especially in children. So let's welcome Dr. Fatima. I believe Dr. Fatima is online. Can I confirm?
Yes, I am. Good afternoon,
okay,
everyone.
Okay, so you have the floor, Dr. Fatima. The allotted time is 15 minutes. We'll appreciate if you could help stick to time. Thank you very much. Over.
Thank you very much. I want to thank you. I want to begin by thanking you for thanking NCDC for this invitation, and also to thank the NCDC director and the rapid response team in what they're doing actually in the outbreak in Kano. I will not waste too much time. I'll just go ahead and share my screen. Can you see my screen?
Yes, please. Go ahead, Dr. Fatima.
Is it a slideshow?
Not yet. You can just put it on. Okay, yeah, so it's fine now. We are good to go.
Right. So already Dr. Bola Lawal has introduced diphtheria. So I'll not miss too much time. The outline is as follows: introduction, pathogenesis, clinical features, treatment, and complications. The organism has been introduced. Just to add that it has 4 Corynebacterium diphtheria has 4 biotypes: gravis, mitis, and belfonti, and intermedius, and all of them can produce an exotoxin. It has a potent polypeptide exotoxin, which inhibits protein synthesis and causes local tissue necrosis. Subsequently, there is local and systemic toxin dissemination, and then there is widespread binding to tissues, including epithelial, nerve, muscle cells, to cause severe local and systemic manifestations. It's good to know that there are also non-toxigenic strains, which often cause local inflammation and mild disease, which is often cutaneous. Occasionally, you can have endocarditis. They are only human carriers are the main reservoir of infection. However, some case reports have linked diphtheria to livestock. Infected patients, asymptomatic carriers, can transmit Corynebacterium diphtheria via respiratory droplets and contact with discharges from skin lesions. The case definition has already been mentioned. Just the pathogenesis here. There's initially a bacteriophage. Sorry. Initially, a bacteriophage toxin goes into the Corynebacterium diphtheria. Subsequently, the organism becomes toxin producing and it binds with a receptor to the cell membrane. It is then taken into the cell cytoplasm, where it actually here works on this enzyme to prevent protein synthesis. Subsequently, there is necrosis. Risk factors include overcrowding, poor availability of health services, incomplete immunization, immunocompromised states, and healthcare workers. One of our medical students actually got infected. Clinical features. Incubation period is 1 to 10 days. Commonly, it is 2 to 5 days. Pharyngeal diphtheria is the commonest presentation. And the immunization status, toxin production, degree of toxin dissemination, the membrane site, the size, and the extent of the membrane determine the disease severity. Initially, it begins as non-specific symptoms of malaise, low-grade pyrexia, loss of appetite, and pharyngitis. Subsequently, there is a pseudomembrane which develops in 2 to 3 days, which varies in size and extent and can extend from the palate to the trachea. There is then cervical lymphadenopathy and surrounding neck tissue edema, which result in a bull neck. The toxin can affect all body tissue. Rarely you can have conjunctival and ears and vulvar, vagina and skin affectation. Atypically, you can have the meninges, the endo and the myocardium, the liver, kidneys, bones and joints, and neural tissues all affected. In infants, there is infection of anterior nares, which commonly occurs with erosive rhinitis, and membrane formation with a serosanguinous purulent exudate that is often foul-smelling. The external nares and upper lip become eroded classically with a shallow ulcer. Cutaneous diphtheria is usually an indolent and non-progressive infection which is characterized by a superficial non-healing ulcer that is covered with a gray-brown membrane. Skin infections can be difficult to differentiate from impetigo. There is pain, there's tenderness and erythema, and it is often a co-infection. It is primary extremity dermatosis, lacerations, burns, and bites that are secondarily infected. The trunk and head are not commonly affected. Rarely, there is respiratory tract infection with toxic complications. The ears and the palpebral conjunctiva are affected. Also, I have mentioned there can be endocarditis and also septic arthritis from diphtheria. These are pictures from some of our patients. This patient had this classical bull neck. This is a patient from the isolation center who has a bull neck also with a distinct neck collar. This picture I took from the public health image library in the CDC. You can see the bull neck very clearly here. Here you can see the patch, the gray, whitish gray patch in the pharynx is more clearly shown here. And here I added this picture because it is not diphtheria, but it is a 3-day post-tonsillectomy picture of somebody who has had tonsillectomy. The membrane, there is a membrane and it also sloughs off. So it's important to know that. This young lady here is a teenager, was admitted in the Diphtheria Isolation Center, and she had vulvovaginal diphtheria. She has been actually treated and has been discharged. Well, alhamdulillah. This is cutaneous diphtheria. You can see the indolent ulcer with distinct margins, and there is a gray membrane over the ulcer. These are our 3 AKTH survivors. Actually, they come from the same family, but from different mothers. They actually recovered well from diphtheria. How do you diagnose diphtheria? It is important to diagnose diphtheria early to prevent mortality and promote isolation. It is mainly clinical, and the history of travel to an area, for instance, here in Nigeria, you might say somebody has been to Kano, to Lagos, or any of the hotspots wherein diphtheria is raging. Immunization history is important, but as you saw from Dr. Bola's presentation, some of the children are actually fully immunized. Nasal and pharyngeal swabs are taken, and selective media culture is done on Loeffler, Telluride, Tyndale, or blood agar. ELEC test has already been mentioned, PCR for the toxic gene, and enzyme immunoassay can be done. Other lab tests, is good to test the immune status. A Schick test can be done. ELISA can also be done. And 0.01 international units per mil is said to be protective. A full blood count of a child with diphtheria may show moderate leukocytosis. And in severe cases, there can be thrombocytopenia. The chest and neck, AP and lateral X-rays may reveal soft tissue swellings in around the pharynx, epiglottis, and the chest. Troponin 1 level will determine the extent of myocardial injury. Differentials are listed. Commonly, it's a respiratory infection. So any pharyngeal infection should be differentiated from diphtheria. But because of this classical membrane, it is actually very easy to differentiate these conditions from diphtheria. Treatment can be specific and supportive. Specific involves isolation and droplet precautions. Consent should be taken before diphtheria antitoxin is given. And also eradicating the diphtheria with antibiotics. Supportive management involves airway management and, where necessary, intubation and tracheostomy and supplemental oxygen. Screening and chemoprophylaxis of contacts is important so that it is not spread within the family and within the community. Bed rest is important for 2 to 3 weeks. More is recommended in those who have myocarditis. It is important during admission to monitor the heart daily. Hydration is important, a high-calorie diet. And Dr. Salma has told me that she's found actually diluted hydrogen peroxide gargle for older children very effective in reducing the treatment time. So in terms of giving that, I mentioned it is important to take a consent, informed consent, and then subsequently there should be a sensitivity testing because there are some that react to the diphtheria antitoxin administration. It is best given IV, diluted in 200 to 500 mils of pneumosaline, and given as a single infusion over 2 to 4 hours, given slowly while monitoring for any hypersensitivity. So in terms of quantity of what to use, those that are diagnosed early or they come to hospital early with pharyngeal or laryngeal disease or skin lesions, you give 20,000 to 40,000 international units. Those that have nasopharyngeal disease, you give 40,000 to 60,000 international units. And those that have extensive disease or it is greater than 3 days or have a bull neck, you have 80,000 to 100. Some reports also mention up to 120,000 international units. It is important to prioritize in cases of shortage, which we are actually experiencing now in Kano. We currently have 74 patients on admission and daily close to 20 patients actually are admitted. So you can prioritize prioritize data administration in these cases. Under 5s should be prioritized, those that have toxigenic strains, and those that present with any severe symptoms, which include stridor or bullneck, fast respiratory rate or chest indrawing, restlessness or lethargy, signs of circulatory collapse, delayed capillary refill or fast heart rate or cold extremities, and central cyanosis. These ones should be prioritized to have that. Complications of diphtheria can include membrane aspiration. When the membrane sloughs up, it can be aspirated, which can lead to suffocation. You can have toxic cardiopathies, arrhythmias, heart block, and circulatory collapse in 10 to 25% of cases, which actually results into 50 to 60% of deaths. You can have polyneuropathy, which is related to diphtheria severity. It tends to occur after maybe 1 to 2 weeks after the diphtheria episode. You can have cranial nerves are the most affected. Extremities, you can have extremity nerve paralysis and paresis. Rarely you can have encephalitis. You can also have acute kidney injury and kidney failure. In cases where antitoxin has not been given and there is unneutralized toxin production, you can have severe disease and circulatory collapse. Respiratory failure, stupor, coma, and death can occur, unfortunately. In conclusion, diphtheria outcome depends on early diagnosis and treatment to prevent any morbidity and mortality. And this can be achieved with a healthcare team that has a high index of suspicion. For improved outcomes, prompt involvement of a multidisciplinary team is key. Thank you very much. This picture I took when I visited the Diphtheria Isolation Center in Murtala. This is the ward where MSF has supported us to manage diphtheria patients. I welcome your comments and questions.
All right, thank you very much, Dr. Fatima, for the very concise presentation. And I must appreciate you for helping us to keep to time. All right, so we're going to have time for questions. I can see lots of them already in the Q&A box, but not until we're done with the last presentation for today. So distinguished senior colleagues and colleagues on the call, I kindly appeal that we please hold on a bit for the responses to the questions so that we have the last presentation. All right, the last presentation focused more for futures among children population. So the last presentation for today's seminar, webinar, so to say, will be focusing on diphtheria in adult population. What's the presentation like, and what are the specific things we need to also look out for as practitioners? And to take us through this is Dr. Hiren E. Akase from LUTH. I think LUTH is University of Lagos Teaching Hospital, not Lagos University Teaching Hospital. So from LUTH, distinguished colleagues, let's welcome Dr. Akase, who will be taking us on this presentation. I'm sure Dr. Akase is on the call, and the floor is now yours for the next 15 minutes. Over to you, Prof.
Thank you, sir. Good afternoon. I believe you can hear me well. Good afternoon, everyone. And
go ahead, sir. We can hear you very clearly.
Okay. Thank you very much to Dr. Lawal and Dr. Hassan Hanga for those wonderful presentation. In the next few minutes, I'll highlight a few peculiarities in terms of how diphtheria affects adults in terms of the issues, the factors, and the prognostic implications. So this has already been addressed, so I will not go into that. But I just want to draw, so when Dr. Bola was presenting, he highlighted the fact that sometimes in the early 90s up to the 2000s, there was an upsurge of diphtheria in Europe, especially in Eastern Europe, Russia, and some parts of the newly independent states of the former USSR. And some of the lessons that were drawn from that outbreak, I think, are very relevant to us now. Some of those issues that were highlighted was, one, the high proportion of cases among adults and adolescents, in that outbreak, which began in urban areas, contrary to what has we expected, that outbreaks would be common among rural areas. It is found to be higher in urban areas, and it was amplified among groups that had high contact rates. So hospitals, Dr. Hassan Hanga has really told us that there was a diagnosis in a medical student and a colleague, among the military and the schools and other areas, NYSC camps and so on and so forth are potential areas, that. Of course, there was high prevalence among people who were socioeconomically disadvantaged, including malnourished people, homeless, and people who were using alcohol and other substances. So clearly, these are lessons that, as we deal with this outbreak in our country, we can draw from. Among adults, there are peculiarities in terms of if you consider the immune responses among different populations of adults. And clearly, experience has shown that the presentation or the affectation among adults is clearly dependent on the type of immunity that's prevalent within that society. So you have two scenarios: one, dependent on the vaccination rates in that community, and two, dependent on the socio-economics or the standard of living within those communities. So if you look at the vaccination rates, there are two scenarios again that have been observed. One, you have areas where there are very low vaccination coverages. In such scenarios, it is thought that people, have high rates of natural infection with diphtheria, some detected, some not detected, and the consequences of which people have some level of circulating antibodies which have been gotten from natural infections, which means that when you look at the type of infection, you see that children are most susceptible to infections and therefore higher mortalities in that age group. But adults, as you would expect, because of survival from natural infections, tend to be better protected, especially when you see people who are 15 years and above. And infants who are born to mothers from those societies seem to have high levels of circulating antibodies. And so, disease among that group seem to be not so severe as one would expect. And then you have the second scenario where you have high vaccine coverages, which is what is seeming to be observed among most societies now, where children are protected because infections with tox-positive strains are rare. Children are protected because they have been vaccinated. But adults are susceptible because the immunity from childhood vaccination is waning. And in most cases, as we see, there is no booster doses administered on a routine basis. So you have what is called an immunity gap, which puts adults at severe predisposition to this infection. Of course, infants who are born to these mothers will not have circulating antibodies. The second scenario, like I had mentioned, was where you have a standard of living is high or low. In low resource settings where there's poor sanitation associated with lower standard of living, you have higher rates of cutaneous diphtheria, as Dr. Hassan Hanga has mentioned, and so therefore people are likely to have circulating antibodies against that. In high income countries, on the other hand, where there are higher, better standards of living, lower exposures, more than 50% of adults, especially individuals more than 50 years, are susceptible to diphtheria infections, especially those that have antibody titer less than the cutoff, as earlier been mentioned. So these two scenarios clearly explains why you may have re-emergence, and clearly we can draw lessons from this in our society. What we don't know, and I'm sure there are questions that can be answered, is one, what is the level of immunity among adults in our society? This is a question that can be answered, and I'm sure. But risk factors for re-emergence in adults have been observed to be lack of primary or child immunization that we mentioned. Secondly, there's waning vaccine-induced immunity because of lack of boosters and low exposure to diphtheria infections and the cutaneous. And then you have increased exposure from all these other risk factors we mentioned: overcrowding, standard of living, migration, travel, and all these are all issues that, and now that we're going to election time where there's going to be a lot of crowding, a lot of travel, there's a possibility that we may be faced with an epidemic among adults, especially now that we don't know the level of immunity that adults in our society have. We clearly know that, childhood vaccination was interrupted at the point in time. Most of the adults who have in their 20s and 30s now had, missed some of their vaccines. So clearly, that is something, we need to look at. What we don't know, though, is how prevalent, what are the circulating strains we have in our society. We know, like Dr. Bola was alluding to earlier on, was surveillance good enough to have detected the circulating, infections, whether they're pharyngitis, how much of the pharyngitis we're having among people who are from diphtheria or from other causes. These are all things that may clearly affect the risk factors, the patients. And then, of course, we couple this with the fact that we are having more people with diabetes, hypertension, and chronic infections, chronic diseases generally. We have a very, robust immunity gap within our society among adults, which can lead to a catastrophic outbreak if that is not taken care of. And then lastly, you have a few infections among those who have been fully vaccinated against the routine infections with tox-negative strains, which means that they are going to have infections as normal skin infections, systemic infections with the bacteria, but without the toxin component. The danger with these is that, as Dr. Bola alluded to earlier on, lysogenization or infection with bacteriophage can occur even among the tox-negative strains, and you can easily have an outbreak of diphtheria even among adults in your hands. So clearly, this points to a large gap, among adults that we need to be aware of as we begin to deal with this, because this clearly could be the beginning of what could be a catastrophic thing if taken care of. So the presentation among adults is not different from what Dr. Hassan Hanga has presented, so I'm not going to all of that, but just to highlight a few differences that based on the type of scenario you have, whether it's low vaccination or high vaccination society, on the other hand, whether it's a low standard of living or high standard of living scenario, and clearly in our country, we see that there are people, even within the same city, you have those who have high standards of living, I have those who are going to have low standards of living, you have a diverse group of people, you are going to be dealing with. So but among adults, you may have atypical presentations, and so they may present with, pharyngitis without your typical pseudomembrane, and milder disease among people who have been partially vaccinated or fully vaccinated, even for that matter, or have survived previous natural exposures. You may expect that, the presentation may not be typical as you would expect. So surveillance is important to detect what are the circulating, among adults presenting with pharyngitis and other forms of that. Secondly, among adults who are non-immunized, presentation, however, is going to be very severe than what you see with children, with a high case fatality rate, as was observed in Russia and parts of Eastern Europe. And then, of course, you may have adults presenting with co-infections, so they may need high index of suspicion to diagnose those. Then for adults who present with severe disease, there's a higher rate, proportion of cases come with complications, as was highlighted, than what Alex had heard earlier on. So among adults, again, the classic or the fossil, as we clearly have seen, may be seen, but then again, like I said, this may not be classical, so the high index of suspicion is required. The nasal diphtheria is mainly among infants and young children, like we heard, so this is uncommon among adults. So clearly, adults may not present with this type of a scenario. The laryngeal, the tracheobronchial diphtheria, again, may present in adults who are poorly immunized, and this can be a common cause of death, among them, because they may have a larger surface area, so they may have a bigger, bigger pseudomembranes that can easily be aspirated and cause obstruction among them. So among adults, this clearly can be a commoner complication than among some of the children, especially adults who are not immunized at all. So complications, again, like she said, may be commoner, like I mentioned, among adults, especially those who are not vaccinated at all, and that's full spectrum. And the risk of these complications is inversely proportional to toxoid vaccinations, but directly proportional to severity of respiratory disease. So when you have an adult presenting with atypical or mild symptoms in adulthood, clearly risk of complication may not be that high, but then again, that can something that can be looked into. we again saw the issue of cutaneous, which is thought to be a big contributor to developing natural immunity among adults, because this is not usually covered in surveillance programs. So people may be going around with tox-negative Corynebacterium diphtheria infections, which may contribute to natural immunity among adults, but on the other hand, may serve as a reservoir for lysogenization and therefore an easy outbreak in a society where the immunity is low among that. But clearly, we see scenarios like this repeatedly among our medical outpatient partners. In terms of peculiarity of diagnosis among adults, again, clinical suspicion, the index has to be very, very high. This is because we know clearly it's common among children, but now that we have an outbreak, and adults who are adult physicians will have to have a higher index of suspicion to be able to pick, knowing that this patient may not come with a typical pseudomembrane, especially if they have natural immunity. So you have to have a high index of suspicion, and surveillance has to be tailored towards this. You know, if we're going to have a clear picture of what kind of scenario we're going to have, I think surveillance has to be tailored to. I know that our case definition, you know, says people who have pharyngitis and a pseudomembrane, but among adults, they may not have that pseudomembrane, but they may serve as a reservoir that can, you know, expose children and other people when they're having tox-positive pharyngitis without that pseudomembrane. So the index of suspicion has to be higher among adults, and of course, when cultures are taken, again, adults have a higher propensity to abuse antibiotics the moment they have pharyngitis. So cultures may be negative. So it may be important to look at alternative sources like, you know, checking among close contacts and also using PCR, you know, instead of, because the cultures may be negative. So you have to use other options in making a diagnosis, you know, among this group. Of course, the ELEC test, to a large extent, where PCR is available, is cumbersome to interpret, and it requires a culture to have been done. So PCR, you know, is becoming more and more. Now we have PCR available in most facilities. It's something that can be used in adults, more useful in adults, is thought, because cultures may be negative, because they've abused antibiotics before they came, and presentation may be atypical. So this is something that can be done. Lastly, in terms of prognosis, mortality in adults may be higher or lower depending on the kind of scenario, whether they have natural immunity in the society or not. Mortality may be higher if it's they don't have that natural immunity, and complications may be more. In terms of the way they present, one delayed presentation, which can be common in adults, and so the delayed in administration of antitoxin may worsen prognosis. Propensity for complications may be higher in adults who are not immunized, and adults who are more than 40 years, of course, as well as children, but adults who are more than 40 years have a worse prognosis when they do present, you know, with severe disease, especially those who are unvaccinated, fully vaccinated. So in summary, diphtheria in adults, it's a peculiarity because of one, the immunity gap that may exist, but also adults may serve as a large pool that can predispose others. And in a society like ours, where there are so many unanswered questions. Number one, how prevalent is natural immunity in our society? We don't have this answer. How does coexisting infections cause an interplay? Clearly, lessons from Eastern Europe have shown that not all adults develop the same level of immunity after a vaccination or even after a natural infection. There are some determinants. For example, we have malaria, we have malnutrition, we have HIV and TB. How do these co-infections affect the development of immunity to diphtheria in adults? That is an unanswered question. What are the circulating strains of diphtheria, especially those that are causing cutaneous and non-toxin mediated infections? What is prevalent, we don't know this. And what proportion of pharyngitis among people presenting in our society is due to, you know, diphtheria, especially those without membranes? Clearly, these are answers that we need to find out. So, but as a close, diphtheria among adults is affected by childhood vaccination programs, as well as socioeconomic characteristics. Presentation may be atypical, and so we need a high index of suspicion. Lastly, mortality is high among adults, especially those with complications and those for whom vaccinations have been done. Thank you very much for listening. Over.
Thank you very much, Dr. Hakase, for walking us through these very concise, straight to the point, enlightening presentation. All right, it's been a very pleasant cocktail, and now we have the floor open. As we bring forward the questions you've brought forward also from the chat box, from the Q&A box, and I'm aware Dr. Yeladun Okuromade, who is the current head of department, epidemiology and surveillance, Department of Nigeria Center for Disease Control, is on standby to walk us through this section where we have this plenary conversation to discuss this topic further. Diphtheria, is it a case of re-emergence, or we just have an improved surveillance in place in the country? Dr. Ladun, over to you as we take this conversation forward.
Thank you, Mr. Biodun, for that introduction. Good afternoon, everyone, and hope we are enjoying the presentation so far. So I'll take us through the next section, walking us through the question and answers, and also we have, we have, in addition to our speakers, we also have, as part of the team that would be helping us to address some of the questions that have been put in the chat box. In the panelists, we have Dr. Olushola Aruna, who is the country rep for the UK HSA. She will also be joining us this afternoon. I want to believe Dr. Kumshida Balami from WHO is also online, as well as Dr. Olayinka Omar Farouk. So to start with, the first question actually is addressed to our first speaker, Dr. Fatima Azan Anga. She presented diphtheria in children, and she also projected the picture of the cutaneous lesion of one of the cases that she has attended to. So the question is it the same species of Corynebacterium that causes the cutaneous lesion, or are we looking at a different organism strain, different from Corynebacterium strain? And the second question also to her is, by clinical presentation, how do you identify a toxigenic strain different from the mild strain of the Corynebacterium diphtheria presentation? The floor is open to you, Dr. Fatima.
Thank you very much. Thank you very much for those very valuable questions. The first is you can get cutaneous diphtheria even from the toxigenic strain, but it is more commonly with the non-toxigenic strain. Again, it is not possible to differentiate whether somebody presenting to you has a toxigenic strain or does not have, except from perhaps the severity of the illness. It is only after it has been taken to the lab, it has been cultured, the Corynebacterium diphtheria has been cultured, and the ELEC test or PCR is done that you can determine whether it is toxigenic or not. But clinically, it is difficult to differentiate. Thank you.
Okay, thank you for that. So I'll move over to Dr. Akase. So there is a question here for Lagos State, that why do diphtheria sample results take long, especially Mushin LGA in Lagos State, that most of the patients have recovered or dead before the results are out? And can you give an overview of the DPT vaccination coverage with among the cases that you treated in Lagos State? Thank you. Over.
Thank you very much for those questions. Well, the first question, I don't think I'll be able to answer why the results take long to come out. I'll have to defer that because I'm not directly involved in that process. But so far, the case in Lagos State, all of them, they were clearly unvaccinated. So none of them had been vaccinated fully. So vaccinated among the cases that were recorded in Lut so far, none had received vaccination. So thank you, and over.
Okay, thank you. So I'll give the floor to the Director General, Dr. Ifedayo Adetifar, to give an answer to why do we have the cases mostly are either recovered or dead before the results are out. Over to you, sir.
Thank you very much, Dr. Ladona. Our colleague, the DSNO from Mushin, I'm not sure that that statement is entirely correct. So when cases are first seen, you have the challenge that clinicians may not recognize them. Or in the case of, I think the first 5 cases or so in Lut, it was not, samples were not taken for confirmation. And sadly, DAT was not available and those patients died. It wasn't, I think it is after those 5 patients presented and were seen that we were notified about diphtheria. We are definitely, we know for sure that in Lut, there's capacity to diagnose diphtheria if a sample is taken. Dr. Philippe Oshun and team are in Lut in the microbiology service and can diagnose diphtheria if they get a sample. So it's a case of, again, the work that we are doing now to increase the index of suspicion among clinicians, because diphtheria is not something that a lot of us have seen in the last decade or two. So people need to now have a heightened sense of suspicion for cases they see, and then take samples for diagnosis. Okay. Back to you, Dr. Latin.
Okay, thank you, DG, for lending your voice to this section. So next, there are a lot of questions on vaccination coverage, immunization. Can close contact be given diphtheria vaccine, and also talking about what is the policy for booster doses of diphtheria. So I would like to state that the next series is actually going to focus on NPHCDA policy as regards this, as well as NPHCDA will be presenting part of their plans concerning that. So we may have to step a lot of questions down until we get to the immunization series. But the next question should goes to Dr. Olushola Aruna. Briefly, we would like to have an idea, just to give us a bit of what UKHSA has been doing to strengthen our laboratory capacity in regards to diphtheria. Over, Dr. Olushola Aruna.
Thank you, Dr. Lano. I hope I'm audible. I can get confirmation that people are hearing.
Yes, very audible.
All right, thank you. Before I go on to the lab work that we've been doing, I just want to go back to that last question about where the DG spoke. And that's also related to how we're able to confirm diagnosis. I think one of the things we also need to think about is some of the surveillance standards that we need to put in place, which cuts across how quickly samples are taken, how quickly they're sent to the lab. Actually, before samples are taken, he's absolutely right. The index of suspicion needs to be quite high. So quick identification, quick sample taking, quick sending to the lab, quick turnaround around lab. So these are standards that I think WHO is asking us to think about, and we need perhaps to put that into place going forwards. So having said that, as Bola, Dr. Lawal alluded to earlier on, I think it was 2022, we were approached by the Nigeria Center for Disease Control, ever before this big outbreak broke, in terms of support to improve or build capacity for diagnosing diphtheria, which we did. We've done quite a few series. So it was just timely that we had already been ongoing with this capacity building at the National Reference Lab and a number of labs, including Lut, 2020. When this outbreak came up, and NCDC had already planned to even expand the laboratory training, which we took up. And a number of university teaching hospitals, including some of those online here, had participants in that training. So we continue to do that. We're training not just on basic culture, but also the confirmatory ELEC test and PCR and name it, including even genomic sequencing if it's needed. So that's an ongoing thing, and we're committed to continue to support that. I think we've trained people now in various hospitals who are actually at this point in time doing step down training in their various labs, which is really, really good. So we intend to continue to support this network to continue to do that as we watch how this evolves. Another thing we're supporting is also the guideline development, which NCDC is leading in terms of laboratory. Some of the questions was around turnaround time. I mentioned that in terms of standards. So these are some aspects I think we'll be anxious to support going forward. I'll leave it for now. Thank you. Over.
Thank you, Dr. Shola, for that extensive support to our diphtheria, to our work in NCDC, most especially in strengthening health security in Nigeria. The next question goes to Dr. Umar Farouk. Just briefly, in terms of community sensitization, mobilizing the key stakeholders in ensuring that they are aware and they get the right information concerning the diphtheria. Can you briefly share with us what are the approaches that you've been taking with the support of our team at different state level? I hope Dr. Lainka is on the call.
It seems she just dropped off now, Mom.
Okay, so hopefully we'll have her back. The next question goes to Dr. Bola. Dr. Bola Lawal. So we have a question here. Actually, I have two questions for you. How available and accessible is that in Osun State? The second question talks about if the prevalence of diphtheria is underestimated, then perhaps we're missing so many other diseases. So what are we going to, how are we going to explore all those that turned out negative? And is there any plan to strengthen surveillance of severe acute respiratory illness, SARI? Lastly, there is another question on, I was happy to hear that there is plan for seroprevalence as it commenced, and where and when. Over.
Okay, thank you very much, Ma, for those questions. Starting with the last, as regards the seroprevalence survey, so yes, it is part of our plan. It's part of our incident action plan to actually conduct some.
So Lawa, your audio quality is low. If you can increase.
Hello, is it better now?
Absolutely, this is okay.
Okay, thank you. So as regards the seroprevalence survey, yes, we have the plan of actually conducting several surveys in not necessarily across all country, but in selected high burden states to be able to gather information as regards the immunity profile and inform, so be in a position to actually guide the National Primary Healthcare Development Agency in the introduction of appropriate vaccine, particularly amongst children greater than 2 that seem to be the affected age group, and also healthcare workers who are actually high risk, at high risk based on their closeness with the cases. So yes, we have that plan on board, and hopefully over the next few weeks we should be able to unravel those plans. As regards that in Osun, like I mentioned earlier on, prior to now, there was no that in country. Upon notification, we made provision for this in collaboration with partners, particularly WHO, to actually make this available in the country. Globally, there's scarcity of that. And we're able to actually procure some, and they need it for us to actually prioritize to high burden states. So most of our data have actually been concentrated in Kano, where we actually have the highest burden. Osun for now has just 1 confirmed case and I guess one suspected case based on the line list we received. So in terms of priority, it is not as pressing as that of Kano and places like Yobe and Lagos. However, we are closely in touch with colleagues at Osun. Whenever the need arise, we have some that preposition at the national level, and will definitely make it accessible to those that need it. As regards the culture positive, the cultural negative results and the possibility of other respiratory tract illnesses, yes. So here at NCDC, we have actually a sentinel surveillance system in place for that's the influenza sentinel surveillance sites that will actually look at investigating some form of respiratory illnesses to look at the possibility of them being as a result of some of the influenza viruses. In addition to that, we're also looking at conducting some form of sentinel surveillance to look at the possibility of not just testing for one particular disease, but looking at an array of possible causes of respiratory tract illness, so as to be able to give explanation for some of the negative results, particularly that we get from some tests like the influenza test that's being conducted for some respiratory tract illnesses. So these are some of the plans we have on board. Of course, it's not exhaustive, and as situation unfolds, we keep reviewing and expanding to cover as much as we can. I think those are the questions. Thank you, and over.
Okay, thank you, Dr. Bola, for that. At this junction, I would like to also invite our Director General to help out with some of the questions that we have here as regards laboratories, the PCR. Sir, so the question is, most hospitals now have PCR. Is it possible to get the needed supply to the molecular lab so as to allow for good turnaround time? And also for samples from Zamfara State, somebody is asking, sir, where do we take our samples to? Over to you, DG.
Okay, thank you very much, Ladu, for the questions. So I think that it's important that colleagues do not sort of keep up with this idea that everything, all capacity building efforts or all of that has to come from the NCDC, or it is strictly related to surveillance. And I think this is an important point to make. Diagnosing patients to identify what they have at the health facility where they present is actually a matter of clinical care. That information, yes, will help us in case there's an outbreak or there's a reportable disease or something that is detected. But the primary reason why we have capacity in health facilities is not for surveillance, it's to look after the patients that present, which is quite different from, say, maybe when you go out and do community surveys and you're trying to find out what's happening. So let's not forget about that, okay? But having said so, the NCDC, of course, does have a mandate to establish and support a network of specialized and reference laboratories, which is a process. And we have established and continue to support a number of labs for priority conditions. Obviously, the focus has been on sort of the epidemic or pandemic or epidemic-prone conditions. So we have networks of labs for cholera, for meningitis, for yellow fever, for measles, for COVID, for monkeypox and Lassa fever and the like. And we cannot build capacity to diagnose every condition across the country at the same time. So diphtheria is a bit of a new front in the battle that we have, although, as Dr. Aruna had earlier mentioned, we proactively had actually started taking steps to build capacity for that. But we cannot establish capacity to diagnose diphtheria in all parts of the country. We have university teaching hospitals. We have departments of microbiology. This is basically what you should be doing, also to complement the efforts of the NCDC and other partners that may step in. But we cannot remove the importance of ensuring that we work, hospitals, state, federal, and we have our own rules to ensure that we have the appropriate test menu in the hospitals that we are in as part of our service to patients. That effort, yes, can be complemented by the NCDC for priority diseases, obviously the notifiable ones, the epidemic and the epidemic-prone ones. But in general, we have to work on our test menu, and the molecular labs that have been set up provide an opportunity to do that. And we are also keen to build on the test menu of the molecular labs that currently exist. And we are currently working, as we speak, on expanding capacity to diagnose diphtheria at the moment. But I mean, it's diphtheria, it can be pertussis, it can be any number of conditions. We will continue to battle all these pathogens, but we can't unfortunately do all of them at the same time. For Zamfara, at the moment, your samples will have to come to Abuja, if I recall correctly, or perhaps, yeah. So the good thing is that compared to, say, last year, at least from January this year, we've put in place quite efficient third-party logistics system to transfer specimens. And so far, specimens have reached, specimens picked up in the morning or early afternoon of any day have reached our lab in Abuja on the same day. And we'll continue to monitor the turnaround time for specimen transportation. Obviously, it's not ideal. It's not the same as testing right in the facility, but as a stopgap measure while we expand capacity and then map states of the country to labs that are in their region, this is the measure that, this is the stopgap measure that we have. But as we speak, we are expanding. I think another lab for testing will open in Kano today, and we are actually planning to expand more. And we're planning to do the same in Lagos. We're planning to do the same in Osun. But, you know, again, it's just to remember that it's just this one agency. We are doing that, but at the same time, we're also responding to what is not what appears to be the largest Lassa fever outbreak in the country. There's meningitis, there's all of the other things to contend with at the same time. So people should not also wait, also do what you can do that is within your power, within your institutions to also build on your microbiology service. All right, back to you.
Okay, thank you. Thank you, sir, for that explanation. Colleagues, we hear now that it has to be a joint effort, and we need joint collaboration if we must win in controlling any priority diseases outbreak. Not only NCDC, there's too much of over-reliance on NCDC efforts. We need to ensure that we all enter on deck. So next on my list, I am a moderator. I hope we still have more time. I'll go to Dr. Akase. Dr. Akase, so we have a question here for you. Please, what is the dose and frequency of azithromycin and penicillin? I don't know, that maybe that was picked up from your presentation. And also, what is the dose of that and route of administration, and why is it needed that samples should be taken before administration of that? Over to you, sir.
Actually, I prefer it doesn't answer that question.
I think we've even lost Dr. Akase. Okay, so we...
Okay, colleagues, I think that, I know that we're a lot of healthcare workers and all of that here, but there is guidance for the use of that. I would prefer that people consult the guidance. We shouldn't be giving prescription information over media in a forum like this, where people may take that as the way to go and to use that. We have guidance for the use of that. That is available on our website, that is available in relevant documents. So please, that information is present there. Thank you.
DG, Thank you for the explanation, sir. So over to Dr. Fatima. Dr. Fatima, please. The question actually exactly stated, Dr. Fatima, please let me know the immunization status of the over 70 children currently on admission at your facility, and what percentage of these affected patients completed routine immunization against diphtheria? So it's still around immunization question. And also, can vaccine failure be a likely reason for the re-emergence of the diphtheria outbreak?
Thank you very much. This question is very loaded.
One last one. Let me just add this, just so that I'll just pack everything together for you. Then, does every diphtheria in a child present with the pseudomembrane? That's exactly the question. Over, Dr. Fatima.
Right. So the first question was about the immunization status of. I'm very sorry, my video is not working. So I tested it this morning, it was, but now it is not working. But anyway, I have not analyzed the patients that are on admission now, but I can hazard a guess that majority of them would not be immunized, but there would also be some that are partially immunized and some that are fully immunized. So ideally, the immunization of diphtheria should be repeated every 5 to 10 years. We have had mothers who got infected from their children that have also been immunized. So the immunity wanes over time. So there should ideally be booster doses. And NCDC currently wants to do a surveillance survey to determine the need for this immunization. The other thing is, I don't know if all patients with diphtheria will present with a pseudomembrane, but most patients with the toxigenic strain would present with a pseudomembrane. Thank you. I think, are those all the questions, or is there another one?
I think maybe at this point, we should just allow you, because there is another question on cutaneous diphtheria, that how can you diagnose timely and promptly, and how can you rule out other cutaneous lesion that can present as a red flag?
Yeah, oftentimes there is a co-infection with either maybe strep or staphylococcus or other infections, actually, where you have also diphtheria. So the important thing to note in terms of cutaneous diphtheria is not to dismiss you're seeing diphtheria in addition to some other organisms. I think they should all be treated. Commonly, it is a secondary infection on some primary dermatological lesion. Thank you.
Thank you very much for the explanation, Dr. Fatima. I'll turn it to Dr. Bola now. Dr. Bola, are you there? I have a series of questions here for you, but I'm going to compress everything into one. The question says that we've heard where samples have been taken and sent to NRL, which is Abuja, and feedback were received that samples are not viable for test, and leaving state and partners in limbo of what next steps to take. So at point of care, when a suspected case is suspected, who is responsible for sample collection? Is it the clinician or the LGA DSNO? And sequel to that, are these people being trained, either DSNO or clinician, on sample collections and the appropriate samples to take, knowing the fact that we are faced as a nation with the expertise on sample collection, storage, and transportation to the NRL? Thank you, and over.
Okay, thank you very much for the questions. As regards the viability of samples, largely it could be due to two reasons. Firstly, it's possible that prior to collection of sample, perhaps antibiotics have been taken, and we no longer have the organism valuable in the sample taking. The other reason for the viability of the sample or non-viability of the sample is using the wrong sample collection material, particularly the sample, the medium for transporting the sample. So there's a specific media that is actually used in sample collection, which is the AMIS media. This is expected to actually preserve the sample and ensure that it actually appears in the lab in a good state. However, when this is not used, the viability of the sample or the organism in the sample cannot actually be ascertained. So perhaps this could be some reasons why we don't have non-viable samples. As regards who to take, so surveillance is actually a joint responsibility. The attending physician, if given the right sample materials and the right training, can go ahead and actually collect the sample. Likewise, the LGADSNO. The most important is to ensure that sample is actually taken at first contact, preferably before the commencement of antibiotics. So depending on who sees the case first and how well they are trained, either the LGADSNO or the attending clinician will go ahead to collect the sample. We all know that the primary responsibility, of course, of investigating a case, which actually includes both collecting epidemiological data in the CIF as well as sample, is that of the LGADSNO, but nothing, of course, stop the clinician from doing that if all the researchers at that point is actually available for him or her to go ahead and collect the samples. As regards training, in the state where we find ourselves, like we said earlier on, diphtheria is something new in quote that we've actually, this is the first time as a country that we're actually responding to the outbreak of diphtheria. So with regards training, we've succeeded in actually building the capacity, particularly in states where we've actually gone ahead to support in terms of response. However, there is plan in we have actually a plan in place to go ahead to build capacity across all states of the country to ensure that surveillance officers as well as clinicians have the requisite knowledge and skills that will enable them to collect appropriate samples.
Okay, Dr. Bola, that's okay. Thank you. Thank you for that. I would like to say thank you to all our panelists and thank you to all the participants for being part of this this webinar. Despite the initial challenge, we say thank you. Over to Mr. Biodun for the next. Thank you.
All right. Oh, okay. The HOD, thank you very much, Dr. Ladun, for helping us to coordinate that section. I believe there are ongoing conversation around diphtheria, cutting across case management and all that. There is a question that has been asked, Dr. Fatima. I think someone was trying to know if intubation increases risk of aspiration. Maybe we get that through a chat box to reply, Dr. Fatima, if you don't mind, because we don't have much time. I've also observed that we have colleagues from the military on the call. Thank you for joining. The military section is also another great collaboration we're looking forward to exploring in capturing the engagement in that area. I'm told Dr. Disu will want to make a few comments regarding risk communication and community engagement interventions. If you can have that in 2 minutes so that we could tidy up this conversation.
So we'll take that to the next series.
Okay, excellent.
So DG is in a hurry.
Okay.
Okay.
All right. So the floor is open. DG, we're so glad you're able to make this to this time. We really appreciate it. We'll be glad to have your closing thoughts on this conversation so far. DG, please.
Again, I'd like to thank everybody for the time. There are 427 participants, still more than an hour after this webinar started. Obviously, it's a very important subject, but we please, just to reassure you that this is just the beginning of what would be a few more conversations on this subject, and we will come back with another opportunity to engage. In addition, please keep, if you follow the NCDC on the all the social media platforms, Facebook, Telegram, Twitter, Instagram and all of the like, we also provide updates, and our website carries situation reports. You can download the reports that give you full epidemiological reports of the outbreak as it evolves as well. I'd like to thank all the speakers, thank all the panelists, thank all of our partners, especially WHO, who helped us with a new link that has so far been not unhackable compared to the first episode we had. We also thank our colleagues in Kano, the State Ministry of Health Authorities, Dr. Fatima Hassan Hanga, and all AKTH authorities. Their response to this outbreak really has been exemplary. The cooperation between state and federal government institutions in terms of outbreak response has also been exemplary, and please should be emulated by other states. The fact that we have federal and state institutions does not mean that we have a domain split as far as emergency preparedness and response. We all serve the same population, and there's a need to coordinate that response. Surveillance is everybody's responsibility. It's not just enough to see. Please, if you see something suspicious, report to your local government DSNO, report to your state DSNO, report to the NCDC. Then they can be investigated and either confirmed as, okay, nothing to worry about, or something to worry about. But the idea is that it allows us to pick up an outbreak soon after it occurs and provides more time to respond, so that we can save lives, we can reduce suffering, and we can also protect our healthcare workers from unknown exposures to both unknown and known dangerous pathogens. I've forgotten also to, let me thank eHealth also for helping with the invitations and with the Zoom link as well, and to the pertussis and diphtheria technical working group for putting this together. Our partners, as on the flyer for this event, UKHSA, Nigeria Infectious Disease Society, Nigeria Society for Pediatric Infectious Diseases, Pediatric Association of Nigeria, and everybody else. We look forward to the next round, where we will bring in, for example, the dermatologist will come in to speak a bit more about cutaneous manifestations, because this is not well described in the country. Our colleagues from MPHCDA will be here to discuss vaccines, and other speakers will be selected according to how the outbreak evolves and what information needs to be shared. And hopefully we'll be also able to provide an update on laboratory strengthening and expansion. Thank you all very much, and it's goodbye for now from the NCDC and team. Thank you all. Bye for now.
All right, thank you very much, DG, and it's thank you to everyone, and see us again at another time. Over from here.